Diabetes with impaired renal function. Letter of referral. Dear Dr. Mr. David Marshall, aged 55 years. Please would you see this man who has had diabetes for the last 10 years, treated with metformin and gliclazide. He is not a frequent attender at the surgery, but he came in last week to consult me about erectile dysfunction. I did some blood tests which showed that his creatinine was elevated at 160 moles/L. I would be grateful for your advice about his management. Yours sincerely. Introduction. Diabetic nephropathy is the commonest cause of end-stage renal failure in the Western world, and its incidence is increasing. In the USA, more than 35% of people with end-stage renal failure have diabetes, and up to 20% of type 1 diabetics eventually develop end-stage renal disease. Only about 10% of patients with type 2 diabetes develop end-stage renal disease, but due to the higher prevalence of type 2 diabetes, 5 to 10-fold, they are the commonest diabetics treated for renal failure. Genetic factors appear to play an important role in the development of diabetic nephropathy, and some ethnic groups, particularly African Americans, persons of Hispanic origin, Native Americans, and Indo-Asians, are predisposed to renal disease as a complication of diabetes. Interestingly, the likelihood of developing new diabetic nephropathy declines 20 years after the onset of type 1 diabetes, suggesting that some individuals are relatively protected. The initial aim in dealing with this case must be to determine whether the overall history is consistent with diabetic nephropathy or if there are any features to suggest an alternative diagnosis. Between 10 and 30% of patients with diabetes who have renal disease are discovered to have a non-diabetic cause of nephropathy. The duration of diabetes is important. In general, the risk of diabetic nephropathy is higher when the duration of diabetes is up to 20 years, although type 2 diabetics may have had the condition for several years before becoming aware of it. Renal impairment is preceded by hyperfiltration, microalbuminuria, and macroalbuminuria. Hypertension is usually present early in the course of the disease. Diabetic nephropathy is more common if diabetic control has been poor, and the condition is unusual in the absence of any diabetic retinopathy. NB. Diabetic nephropathy is very common, but diabetics with renal impairment may have another diagnosis, for example obstructive uropathy, plasma cell dyscrasia, or renovascular disease. History of the presenting problem. Related to renal disease. Although the referral letter suggests that the patient has no systemic symptoms other than erectile dysfunction and the strong suspicion is that he has diabetic nephropathy, it is important to probe the history thoroughly, as he may have renal failure due to a cause other than diabetes. Crucially, this might be acute and potentially reversible. Related to diabetes. It is important to ask about the following. Monitoring of diabetes. How is the patient assessing his diabetic control? Occasional patients are still using urine testing, which is certainly inappropriate in the presence of renal disease. How often is he checking his blood sugar, at what times of day, and what values have been obtained? Part of the management of diabetic nephropathy is to optimize diabetic control. Hypertension. Has his BP been checked regularly, and does he know what readings have been obtained? Obtaining good control of BP will be crucial in this case, whatever the cause of renal impairment. Retinopathy. Has the patient ever been told there is a problem with his eyes? Are his eyes checked regularly for signs of diabetic damage? Has he ever had laser treatment? Neuropathy. Does he get any numbness, pins and needles, or funny feelings in his toes and or fingers, which would indicate peripheral neuropathy? Macrovascular disease. Has he suffered from angina/myocardial infarction, transient ischemic attacks / amaurosis fugax / stroke or intermittent claudication. If these are prominent features, then renovascular disease requires consideration. Feet, has he had ulcers, which could be caused by neuropathy, ischemia, or both? NB. Diabetic nephropathy with renal impairment is almost always associated with some diabetic retinopathy. If this is not present, you need to seek another renal diagnosis. Other relevant history. It will be important to obtain a proper smoking history. The combination of diabetes, renal impairment, and smoking is devastating to health. Plan for investigation and management. Investigations aim to determine whether diabetic nephropathy is the most likely cause of the renal impairment and should include the following. Urine tests. Dipstick testing would typically reveal significant proteinuria, 2 or more, but no hematuria in a patient with renal impairment due to diabetic nephropathy. Microscopic hematuria and the absence of proteinuria are both unusual in diabetic nephropathy, and either of these findings should raise the possibility of another diagnosis. If microscopic hematuria is observed, then urine microscopy should be performed. The presence of red cell casts would strongly suggest that diabetic nephropathy was not the diagnosis. Quantitate proteinuria by estimation of urinary albumin/creatinine ratio or 24-hour urinary protein excretion. ACR greater than 3 mg is termed as microalbuminuria and greater than 30 mg is termed as overt proteinuria. Blood tests. Serum creatinine to determine the current level of renal function and rate of decline, if previous values are available. Cholesterol and triglycerides to help quantitate cardiovascular risk. HbA1c to determine medium-term glycemic control. FBC, deficiency of erythropoietin and renal anemia often occur relatively early in the course of diabetic renal disease. To rule out other causes of renal impairment, consider serum and urine protein electrophoresis. Plasma cell dyscrasias are a common cause of renal impairment in this age group, and also immunological tests including antineutrophil cytoplasmic antibodies, antinuclear factor, and complement to exclude immunologically mediated renal disease, but note that hypocomplementemia may be a feature of cholesterol embolization syndrome. Urinary tract ultrasonography. In contrast with most other causes of chronic renal failure, renal size is often normal in patients with diabetic nephropathy. Disparity in renal size, greater than 1.5 cm difference in kidney length, may suggest renovascular disease or reflux nephropathy, and irregular renal outlines may indicate congenital dysplasia/reflux nephropathy/chronic pyelonephritis. Check that the patient's bladder empties properly. Neglected obstruction is a common cause of renal impairment in elderly men. Other tests. Perform an ECG to look for evidence of previous myocardial infarction or left ventricular hypertrophy. Conduct magnetic resonance angiography if the history, examination findings, or ultrasonography suggest renovascular disease, but only if you would proceed to angiography and renal artery angioplasty/stenting if renal artery stenosis is demonstrated. Consider renal biopsy if there are any features to suggest a non-diabetic cause of the renal impairment other than renovascular disease, e.g. an absence of previous proteinuria or retinopathy, sudden onset of nephrotic syndrome or the presence of red cell casts on urine microscopy. NB. If the history and clinical findings are consistent with diabetic nephropathy, it is usually not appropriate to undertake a renal biopsy. Management. Aside from issues common to all diabetics, e.g. regular eye and foot checks, issues of particular importance in this case include the following. Review of current drug therapy. Metformin can cause lactic acidosis in advanced renal impairment and should probably be discontinued in this case. NICE recommended to discontinue if creatinine greater than 150 or eGFR less than 30. BP control, the most important determinant of the rate of progression of diabetic renal impairment. BP should be maintained as low as tolerated, less than 130/80 mmHg if achievable without unacceptable side effects, using an angiotensin-converting enzyme, ACE, inhibitor. The combination with an angiotensin II receptor blocking agent is no longer recommended. Other antihypertensive agents may need to be added. Modest restriction of salt intake can help to achieve BP targets. Management of cardiovascular risk: encourage the patient to stop smoking, if necessary, and take exercise, reduce cholesterol using a statin. Glycemic control: improvement may slow the progression of early diabetic nephropathy but is less important than BP control. NB. Management of diabetic nephropathy is with ACE inhibitors in addition antihypertensive agents as necessary, aiming for BP less than 130/80 mmHg. Management of cardiovascular risk and macrovascular arterial disease is essential in patients with diabetic nephropathy. Further discussion. Blockade of the renin-angiotensin axis. Even in the absence of hypertension, there is evidence that progression of diabetic renal failure is slowed by ACE inhibitors and angiotensin II receptor blockers. Their use in combination is more effective than either class of agent alone. Renovascular disease. Renovascular disease may coexist with diabetic nephropathy and should be considered in all diabetic patients with renal impairment. Hence, it is always important to check renal function 7 to 10 days after starting an ACE inhibitor or angiotensin II receptor blocker to ensure there is no acute deterioration. The decision to undertake angioplasty and stenting of stenotic lesions in renovascular disease needs careful consideration and is the subject of ongoing trials. Prognosis of diabetic nephropathy. Diabetic nephropathy is usually inexorably progressive and patients with diabetes have a reduced survival rate compared with other causes of renal failure. Once renal replacement therapy is instituted, mortality among type 2 diabetics is up to 25% per year.